Hello everyone, I am Dr. Atim. So here this will be the continuation of the heart first pipetting. So here we'll see about all valvular heart disease. So coming to rheumatic fever as well as rheumatic heart disease. This rheumatic fever is nothing but a acute immunological mediated multi-system inflammatory disease which usually occurs few weeks, that is after 10 days or 6 weeks following a group A streptococcal pharyngitis or after a skin infection. This acute rheumatic fever is seen in 3% of the patient, and the common age group affected will be around 5 to 15 years of age. So the pathogenesis behind this rheumatic fever is nothing but type 2 hypersensitivity reaction. So antibodies as well as CD4 T cells which are directed against the streptococcal B proteins will also act against the cardiac self antigen and other tissue due to molecular mimicry or a cross reactivity. So coming to the gross as well as microscopic features seen in rheumatic fever, the microscopic feature will be characteristic Ascope bodies as well as aniscope cells. So Ascope bodies is nothing but it contains T lymphocyte, plasma cell as well as aniscope cells. So aniscope cell is nothing but activated macrophages. Okay, these are also called as caterpillar cells because here the chromatin will be condensed, slender and wavy ribbon like, and it also has a abundant cytoplasm. So this is a microscopic feature showing the aniscope cells, and this is the Ascope bodies showing aniscope cells, plasma cells and as well as T lymphocytes. So other gross findings seen in patients with rheumatic heart disease will be pancarditis, and there may be also fibrinoid necrosis of the cusp as well as chordae tendineae, and next characteristic will be vegetation. Here the vegetation will be very small. It is around about 1 to 2 mm and they are seen along the line of closure. Okay, and this vegetation is called as verrucae. There may be also irregular thickening called as McCallum plaques. Okay, this is an important MCQ. These are seen frequently in the left atrium. So the most common walls to be involved in the rheumatic heart disease is mitral wall, and the anatomical changes seen in the mitral wall will be leaflet thickening, commissural fusion and shortening and thickening as well as fusion of the chordae tendineae. So remember there will be pancarditis, mitral wall involved. So mitral wall stenosis is the most commonly seen in the patient with rheumatic heart disease, and McCallum plaques. So we have already discussed in rheumatic heart disease there will be mitral valve stenosis. Here the stenosis will resemble a fish mouth. So this is called as a fish mouth stenosis. So this is also an important question. They can ask in MCQ. So the criteria used for diagnosis of rheumatic heart disease is revised Jones criteria. So go through this table column once, that is major, minor as well as supporting evidence. So supporting evidence is these are the 3 points which indicates the presence of streptococcal infection. So you may get easily confused like elevated or rising ASO titer is a major criteria or not. This is not a major criteria. This is a supporting evidence. Okay. So go through this table column once. So they can ask what and all the major criteria except. Okay. They can give elevated rising ASO titer in that. So ASO rising titer is a supporting evidence, not a criteria to diagnose rheumatic heart disease. So coming to infective endocarditis. So infective endocarditis is nothing but a microbial infection of the heart wall or a mural endocardium. So there will be a formation of vegetation, and this vegetation composed of thrombotic debris as well as organism, and there may be also damage to the underlying cardiac tissue. So this infective endocarditis can be of acute as well as subacute type. So we'll see the difference between acute IF as well as subacute IF. So in acute IF, it involves the previously normal walls. Okay. In subacute IF, the damaged walls will be involved. So this here the damage can be due to rheumatic heart disease, mitral wall prolapse, calcified walls, prosthetic walls, or due to any congenital defects. So the organism which has been isolated from the acute IF is of highly virulent organism like Staph aureus. In subacute IF, we can see lower virulence organism, maybe due to streptococci viridans. Okay. So in acute IF, it is difficult to treat by antibodies alone. However, in subacute, they respond well with antibodies. So this is this side. There is many important MCQ in this side. So go through it twice. So we'll see they can ask organism which most commonly involved in IF. If the patient with damaged walls, they can ask any question. So in IF, The most commonly organism which has been isolated in a patient with previously damaged or abnormal cardiac wall is Streptococcus viridans. Okay, so in patient with healthy walls or intravenous drug abusers, so the organism involved is Staphylococcus aureus, and in patient with prosthetic walls, the organism involved is Staphylococcus epidermatitis. Here the endocarditis usually develop within 1 to 2 months after a surgical implantation. Okay. So other bacteria which has been isolated from the patient with IF are Enterococci as well as HASEC group of organisms. Just go through this table column once. So the morphology seen in infective endocarditis are there will be vegetation in the heart walls, and this vegetation is friable and bulky, okay, and they extend even to the caudate. So as they are friable, this increases the chance of embolisms, okay. So they may embolize to other organs causing septic infarct, or they can also cause mycotic aneurysms, okay. So the most important walls involved are aortic as well as mitral wall. So mitral wall is most commonly involved in rheumatic heart disease. Here aortic as well as mitral walls are involved, and walls of the right side heart can be also involved in the patients with intravenous drug abuses. Okay, here the vegetation can be single or multiple, and there may also increase the risk of ring abscess in this patient with infective endocarditis. So remember here the vegetation can be single or multiple, and they are friable, so this increases the risk of embolization. Okay, and they are seen, and this vegetation can extend even to the caudate. Okay, and the ring abscess is important MCQ. So clinical feature, the patient may come with fever, chills, weakness as well as murmurs, and there may be also Janway lesions, osseous nose and root spurs. These are nothing but they are formed as a result of embolic events. And diagnosis of infective endocarditis is mainly by means of modified Dukes criteria. So this table column shows the modified Dukes criteria. Here there is a major as well as minor criteria. So major criteria, there will be blood culture or positive for the organism, or a previously positive for unusual organisms, or echocardiogram finding, or new valvular regurgitation. Minor criteria can be of previous heart lesion or intravenous drug use, or fever, and as well as Janway, osseous nose, road spurs, everything. Just go through it once. So complications seen in infective endocarditis is glomerulonephritis due to the antigen antibody complex, sepsis, as well as systemic embolism, as the vegetation here you see is friable, and arrhythmia due to the damaging in the underlying conducting system of the heart. So coming to next one, non-bacterial thrombotic endocarditis. Here there will be deposition of the sterile vegetation. Okay, the vegetation here is sterile, there is no organism involved, and this vegetation is small. Okay, and they are seen along the line of closure of the walls, and they are non-destructive and they do not elicit any inflammatory reaction. So where this vegetation is seen is, these are seen in the patient with the end-stage cancer disease, sepsis, as well as hypercoagulable states. Okay. So this is seen in hypercoagulable states and end-stage cancer and sepsis, and they are sterile vegetations and seen along the line of closure. So previously rheumatic heart disease, there also the vegetation was seen along the line of closure. So coming to Lippmann-Sachs disease, these are seen in the patient with SLE. So here the vegetations are formed as a result of immune complex deposition. Okay, and these are sterile vegetation, and here the vegetation can occur anywhere in the walls. Okay, they can occur in the walls, caudate, atrium, as well as ventricular endocardium. Okay, and there is an intense valvulitis as well as fibrinoid necrosis of the valve substance. So here in any vegetation which occurs anywhere in the wall is Lippmann-Sachs disease. That's an important MCQ and is associated with SLE. So coming to valvular heart disease, so aortic stenosis, the most important cause is calcification, and it can be also age-related changes which can also result to aortic stenosis, or congenitally bicuspid valves. And aortic insufficiency can occur secondary to hypertension or aging. And mitral stenosis, the most common cause is rheumatic heart disease. We have seen that fish mouth stenosis is seen in the rheumatic heart disease. The most important cause of MS, that is mitral stenosis, will be rheumatic heart disease. Mitral insufficiency is the most important cause will be mitral wall prolapse, okay, or ventricular dilatation due to ischemic or non-ischemic heart failure. Coming to mitral wall prolapse, In mitral valve prolapse, one or both the leaflet of the mitral wall become floppy, okay, and they protrude into the left atrium during systole. Due to the protrusion, it produces anatomical changes called ballooning or hooding of the mitral leaflets into the left atrium. So the syndrome associated is Marfan syndrome, and the histological changes seen in mitral valve prolapses, there will be a myxomatous degeneration of the spongiosal layer. That is an important MCQ. So coming to the clinical feature, most of the patient will be asymptomatic. However, few patient will have exertional anginal pain or dyspnea. And during a routine checkup, these patients will have a mid-systolic clicks. So any MCQ telling there is the presence of mid-systolic click, first think of mitral valve prolapse. And the diagnosis is mainly based on echocardiogram. So the complication behind the mitral valve prolapse are infective endocarditis, mitral insufficiency, stroke as well as arrhythmia. So coming to hypertensive heart disease, this can be of left-sided or right-sided hypertensive heart disease. Left-sided hypertensive heart disease nothing but systemic hypertensive heart disease. So the criteria is there will be a left ventricular hypertrophy, usually of concentric type, and there will be also clinical evidence of hypertension in other organs. So in this patient, there will be increase in weight of the heart, usually more than 500 gram, and the left ventricular wall thickness can be more than of 2 centimeter. Coming to right-sided or pulmonary hypertensive heart disease, this is we have already discussed in the first PPT of heart. So this is nothing but cor pulmonale. So this is the list of disease which results in heart failure. Here there will be a right ventricular dilatation as well as hypertrophy, and usually results into right ventricular pressure overload. This heart failure usually occurs due to right ventricular pressure overload. So the morphological changes seen in the right ventricular heart failures are the normal crescent shape of the right ventricular will be transformed into a ovoid shape, and the right ventricular wall thickness will be up to or more than 1 centimeter. So we'll discuss a few important questions. First is, a young female came to the routine checkup. On examination, mid-systolic click. So we have already seen mid-systolic seen in which disease? That is seen in mitral valve prolapse. There is no history of RHD, and the histopathological examination is most rare. So in mitral valve prolapse, the histopathological examination is myxomatous degeneration as well as prolapse of mitral valve. So the answer is A. Next question. Which one of the following is not included as a major criteria in Jones? So Jones criteria is seen in which diseases? It is seen in rheumatic heart disease. So pancarditis, arthritis, subcutaneous nodules are seen in major criteria. Elevated ESR is seen as a minor criteria. So the answer is elevated ESR. The mechanism for development of acute rheumatic fever is, so acute rheumatic fever is it is of the pathogenesis is type 2 hypersensitivity reaction, and the antibodies which are formed against the streptococcal antigen will react against the cardiac tissue also. So cross reactivity with the exogenous antigen is the answer. Coming to next one, the most friable vegetation. So the most friable. So we have seen in infective endocarditis, the vegetation will be bulky and friable. So this increases the risk of embolisms. So the answer is infective endocarditis. Next question, Ascough nodules are seen in. So we have seen Ascough nodules are seen in rheumatic heart disease. So another Ascough nodules is nothing but it contains T lymphocytes, plasma cells as well as aniscose bodies. So it is seen in rheumatic carditis. Next, a 10-year-old boy died of acute rheumatic fever. Which of the following is not seen in bodies? So Ascough nodules are seen, McCallum patches are seen, fibrinous pericarditis seen. Only rupture of chordae tendineae is not seen. These are seen in infective endocarditis. So not true about ASO titer. So ASO titer is related to rheumatic heart disease. So this is not a major Jones criteria. This is a supporting evidence. We have already discussed in the table column. So the answer is major Jones criteria. So which of the following is not a complication of infective endocarditis? So ring abscess is a most important complication. Myocardial infarction is not a complication of infective endocarditis. just go through the previous, we have already discussed that. Okay, glomerulonephritis is a complication, pericarditis is a complication of infective endocarditis, ring abscess is also an important complication of infective endocarditis. So MI is not a complication. So Ascough borders in rheumatic heart disease shows all except aniscough cells. Epithelioid cells it does not shows. Okay, so the answer is epithelioid cells. Okay. So vegetation on the undersurface of cups are found in. So vegetation can be found anywhere on the cardiac walls or in the myocardium is Lippmann sac endocarditis. So the answer is Lippmann sac endocarditis. So the most common cause of mitral stenosis is rheumatic heart disease. Okay, we have already seen the fish mouth stenosis is seen in rheumatic heart disease. So mitral valve stenosis is seen in rheumatic heart disease. So mitral valve vegetation do not embolize to. So mitral valve vegetation, this is a common question. Okay, mitral valve vegetation do not embolize usually to lung. Okay, so mitral valve is seen in the left side chamber of the heart. So this the vegetation over the mitral valve cannot go back to lung. So the answer is lung. So the most common heart valve involved in IV drug abusers is tricuspid valve. Okay. And chronic constrictive pericarditis is most commonly caused by TB.